So good afternoon, everybody. I'd like to welcome you to this afternoon's meeting of the BCP Council Health and Wellbeing Board. My name's Sam Crowe. I'm the Director of Public Health, and I've assumed the chair on a temporary basis just to take us through the first 3 items or so before we formally proceed to the formal election of a chair for the remainder of the session. So I'd like to welcome you all to the board this afternoon, and I'll just begin by making the first initial comments. To those board members who've joined the meeting in person, to those who are joining remotely, I'll hand over to Karen to make the opening announcements. Thank you.
Many thanks. If I can just refer to the housekeeping arrangements for the meeting. Just to advise, this meeting of the board is being recorded by the council for live broadcast and will be published on the council's website for a minimum of 6 months. With regards to the arrangements and ground rules for this afternoon's meeting, please could everyone present follow, only speak when invited to by the chair. Please use the microphones on your desk when speaking, and please turn off your microphone when you're not talking. If accessing the meeting via Teams, and obviously we have a number of people this afternoon doing that, please turn on your video function when invited to speak. If you are accessing via Teams and would like to speak on an item, please do so by utilising the raise your hand feature in the bar at the top of the windows. Just to confirm, only those members of the board present in the room will be able to vote if we get to a formal vote this afternoon. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the ground floor of the multi-storey car park. Finally, please can I ask to ensure background noise is kept to a minimum and mobile phones and other devices are turned off or switched to silent for the duration of the meeting. If you're happy, I'll move on to apologies for the meeting.
Yes, thanks very much, Karen. We could have them.
So, just to advise, I've received apologies from Tim Goodson, Kathy Hadley, I'll go on to substitute members shortly, Scott Chilton, Chief Constable, Sally Sandcraft, Richard Jenkinson, Debbie Fleming, Karen Loftus and Mark House. Graham Farrant hopes to join us at about 3 o'clock and he apologises that he's not able to be here from the start of the meeting but has another commitment. Have I missed any apologies?
Just so I'm going to have to leave early.
Okay.
That's okay.
Okay.
I am here.
Thank you. So moving on to agenda item 2, substitute members. Can I welcome Rachel Gravitt to the meeting? She is the formal substitute for Kathy Hadley, who is our Corporate Director for Children's. I'm not aware of any other substitutes. So that moves us on to agenda item 3, which is election of chair for the remainder of the municipal year.
Thank you very much, Karen. So I'm now going to ask the board for nominations for the role of chairman and request if you could indicate by raising your hand if you'd like to nominate someone. And Councillor White.
Yeah, thank you, Chair. I'd like to nominate Councillor Karen Rankin. Thank you.
Thank you very much. So just a matter of process, if there are more than 2 members of the board nominated, then we'll have to do a secret ballot. But as I can't see any other requests, I'm assuming, do we have a seconder? Thank you. Thank you, Councillor Kelly. So congratulations. Councillor Rampton is elected as chair. So I'm now going to hand over to the new chairman of the board.
Thank you, Sam. Thanks, everyone. Thank you, everybody. So moving on to item 4, which is declarations of interest. Do we have any declarations, please? And I'm not seeing any hands up. It's the first time I've chaired one of these hybrid meetings. It's quite difficult going between all these different screens. So we're moving on to item 5, public issues. I'm not aware of any public issues which have come forward. Are there any, Karen?
No, Chair.
Nope, not this time. Thank you. So moving on to item 6, confirmation of the minutes. The meeting held on the 14th of October last year. Has everybody had a chance to look at the minutes, and are there any corrections anyone would like to make or any points to raise? Again, I'm not seeing any. I'll sign those as a correct record, thank you. Item 7 is membership of the board, and Karen, could you please update us?
Just by way of update, we obviously have had some changes to the membership of the board. If I can welcome new portfolio holder, Councillor Mohan Iyengar, who is joining us remotely, who's now a member of the board, and also to Jane Kelly, who's one of our lead members, and she's joining as a fully fledged member of the board. I don't think I'm aware of any other changes, Chairman, unless anybody's got any particular updates. No, I'm not. Think that's it.
I'm not seeing any. Do we know each other, or should we go around to do some introductions? Okay, so I'm going to start. I'm going to start with Karen.
Hello, I'm Karen Tompkins. I'm the Deputy Head of Democratic Services, and I support the Health and Wellbeing Board.
Yep. Okay, David.
Good afternoon, I'm David Vitty. I'm the Director of Adult Social Services for BCP Council.
Hi, I'm Simon Watkins. I'm a GP at Evergreen Oak Surgery, which is just down the road from here. But I also do work with the CCG as well.
Thank you.
Hi, I'm Rachel Quafford, Head of QA, Governance and Improvement of Children's Services, here for Cathy Hadley today, DCS, the BCP Council.
Thank you.
Hi, I'm Jess Gibbons. I'm the new Chief Operations Officer for BCP Council.
Hi, I'm Natasha Morris. I'm the team leader at the intelligence team at Public Health Dorset.
Good afternoon, everybody. Sam Crowe, Joint Director of Public Health, BCP and Dorset Councils.
Good afternoon, Councillor Jane Kelly. I'm the lead member for communities.
Yeah, good afternoon, Councillor Mike White. I'm the lead member for Children's Services, with particular responsibility for children's social care.
Hello, I'm Angela Fendley, and I'm here with the Poverty Truth Commission today.
Thank you.
I'm Emily Bradbury, and I'm also here for the Poverty Truth Commission.
Thank you. I will bring in the members. I'm Karen Rampton, and I'm the portfolio holder for People and Homes. And I can see Councillor Iyengar.
Yeah, thank you. Mohan Iyengar, Cabinet Member for Active Health and Tourism, which includes liaison with public health and also all the sports and leisure side of the council. Thank you.
Louise.
Hi, I'm Louise Bate. I'm the manager at Healthwatch Dorset. Nice to see you all.
Thanks, Louise. Eugene.
Afternoon, colleagues. Eugene Ufeli, I'm Chief of Care NHS Foundation Trust.
Thank you, Eugene. No, I'm not seeing faces for other people. Karen, are you able to help me? I think we've got. Do we have Kat?
Good afternoon. I'm Kat McMillan, Head of Community Engagement. Apologies, I will need to leave at 3 o'clock for another meeting. Nice to meet you all.
Okay, thanks, Kat. Kirsty?
Hi, I'm Kirsty Hillier, Head of Communications for Dorset's Integrated Care System.
Thank you, Kirsty. Natasha? Oh, sorry. Paul. Paul?
Afternoon, everyone. Paul Iggulden, Public Health Consultant in the Public Health Dorset team and ICS Health Inequalities Programme Director.
And Steve? Steve, please.
Sorry, just putting my camera on. It's being slow. Hi, I'm Steve Place from Community Action Network. I'm here instead of Karen Loftus, who sits on the board representing the voluntary and community sector.
Thanks, Steve. You're very welcome. I'm not can't see that I've missed anyone, but if I have, please speak up now. No. Great. Thanks, everybody. So we're moving on to item 8, and I think that's you, Sam, isn't it? You're going to take us through an update on living with COVID.
Thanks very much, Chair. So I'm not going to show slides this afternoon, but I'm going to base a verbal update on the presentation that I gave to the Health Overview and Scrutiny Committee earlier this week. And the point of this presentation to the Health and Wellbeing Board this afternoon is just to be clear with board members about how we're going to continue to respond to COVID in the light of the change to the national strategy, which was announced on the 21st of February, which was the Living with COVID plan. So I'll start with the current situation. We obviously had quite a big peak of Omicron in January. We then started to see rates fall back. Throughout late January and early February, they did start to climb again, partly driven by the return of schools. The infection rates appear to be falling back in BCP Council, quite similar to other councils in the southwest. But there is a big caveat currently with the data, which is we are changing the way that we are using our testing services. And many of you will be aware that the free testing, particularly the PCR testing, that's been available most of the way through the pandemic, is going to stop on the 1st of April. So this is no longer an effective way of local surveillance for COVID. In its place, we have a national seroprevalence survey, which is run by the Office of National Statistics. That's carried out every couple of weeks, and that provides a reasonable population estimate of the proportion of the population who have COVID. So although we can still provide data based on our testing rates locally, because of the change in testing behaviour, that's no longer considered to be accurate. So we've seen about a 40% fall off in use of PCR testing. So there are lots and lots of people who are getting infected and not bothering to test. So I wouldn't set too much store by the data at this point. Then the important thing for the Health and Wellbeing Board is what is the role of the Health and Wellbeing Board in overseeing particularly the Local Outbreak Engagement Board. So right from the start, when local authorities were requested to step over the line and assist with the response to the pandemic, the local public health team, working alongside colleagues in the NHS, adult social care sector, schools, have led this huge multi-agency effort locally to develop a local day response. So we support a range of settings with their infection prevention and control measures and their outbreak management, all coordinated through a local outbreak management plan. Now, the role of the Health and Wellbeing Board has been to provide members to sit on the Local Outbreak Engagement Board, and we've used that board throughout the pandemic to test and identify key communications messages and issues that we feel it's important to engage with the public on. Having met with the board, both boards actually, BCP Council's board and Dorset Council's board, in the light of the strategy, we've decided to pause the Local Outbreak Engagement Board for now, because the national plan says that we will be going back to a sort of very straightforward reminder of public health measures, but we're certainly not doing the sort of in-depth engagement that we were having to do at the height of the emergency. So the strategy announced by the Prime Minister has triggered a whole series of changes and the lifting of all of the legal restrictions and regulations, and the country is moving to a strategy which is focusing on the protection of the highest risk settings and the most vulnerable, and moving away from a public health approach of testing and breaking chains of transmission. So it's important to acknowledge that, and we need to fall in line with that following some of the letters that we've received from government. So we will be maintaining the Health Protection Board. So we've run a multi-agency Health Protection Board right from the start. That will remain. But the board's remit and focus will shift slightly. It will become more broad. We won't just be looking at COVID. We'll also be looking at preparations for other infections like flu, for example. And one of the development pieces of work that that board has to do over the next few months is make sure that we've got an effective and efficient and robust health protection function in our integrated care system. So it's not just about the role of local councils. We'll also be asking that question of our NHS colleagues. So I'm sure you're all aware of the changes to the regulations, but a very quick summary of those is I've mentioned that universal free PCR testing will end on the 1st of April. The legal requirement to self-isolate ended, and all of the associated test and trace support payments also ended on the 24th of February. That also means that contact tracing nationally finished on the 24th of February. So NHS test and trace was wound up, and that also had implications for the 2 contact tracing teams that we've been running under each council. So we are in discussions with both of those teams to look at how we retain some of the skilled people who've been absolutely pulling a shift locally, and I'd like to publicly thank those teams today because they have been really at the sharp end, really trying to make sure that we've got a much better local connection to those families where people were testing positive and needed to be followed up. So I just would like to pause and acknowledge the board's thanks for everyone who's involved in that effort. Some of them may be joining the day response team going forwards, and I believe other people are discussing redeployment opportunities within both councils. So we're not losing capacity, but we are starting a conversation about how we deploy those people in different roles. There is no evidence of new variants currently in the country that would pose a risk. We have 2 currently. There's the Omicron BA1, which caused most of the cases in January. And we've also got a twist on Omicron called BA2, which is very similar. It's not causing any more severe disease, but it is probably accounting for most of the cases at the moment. We'll continue to obviously keep that under review. The big question at the moment is if the situation changes, what is the plan for the country to then respond and stand back up quickly? So we are in close contact with the regional partnership teams who are starting to think about how we would access testing resources and outbreak support if we started to see a very different pattern. So in the interim period, what we are doing is continuing to offer a day response to our higher risk settings. We're reviewing the national guidance as it comes in and changes, and we'll be publishing that in a very brief updated local outbreak management plan. We have taken the decision to wind up a targeted community testing programme, which will finish on the 31st of March. That's on the strong advice of government. It's no longer funded. We will be keeping a limited supply of lateral flow tests for use in investigation of clusters, and in certain instances where there may be people in frontline roles who are particularly wanting to continue to lateral flow test because of the types of settings that they visit because of their role. As I've said, we're working with both contact tracing teams to look at retaining people who still want to work on the COVID response and then find alternative roles and redeploy other people in the team. And I think just finally, just a couple of words on the vaccination programme. Locally, following a successful booster programme, I think most of the people involved in the delivery have noticed that there's been a big drop-off. About 83% of the eligible groups eventually had their booster, which was huge progress. There still remain significant pockets in the population that never had dose 1, never had dose 2, and subsequently wouldn't be included in those figures. When we say 83% of the eligible population, you're seeing a drop-off in numbers as you go through the different rounds of vaccination. So the public health team will continue to work with the vaccination programme locally. There's a lot of thought at the moment going into how we design a more resilient and sustainable service rather than an emergency service. And we'll be continuing the work, particularly around trusted voices and vaccine ambassadors, because that's one of the most effective ways that we've been able to work with communities to understand concerns about vaccination and in many cases overcome and address those concerns and support people to successfully complete their vaccination programme. So I think the next big news in the vaccination programme will be in the autumn. I think there'll be further development of vaccines, and we will wait and see what the national strategy is, whether it's further boosters or actually we'll be developing new covalent vaccines. But I think the next big effort will be required when we're coming off the back of the summer and thinking about how we go into the winter period. So that's my update, Chair. I'm happy to take questions.
Thank you, Sam. That was actually really helpful. I've just got one quick question, if I may. Am I right in thinking there's a COVID helpline number? And if there is that going to stay, or is that something that's going to be wound down as well?
I'll have to check on that. I'm not aware. Is this a local COVID helpline number or something nationally? It's national, is it?
That's my understanding.
I'll take
a family member who phoned it and got some very interesting advice, which wasn't particularly helpful. So
you always learn something coming to the health and wellbeing board. I'll take that away and provide a post-meeting note if that's okay.
Opening the floor up to questions or comments for Sam. Not seeing any, so I think you've answered all our questions. No one on. No. Thank you very much, Sam. So moving on to item 9 on the agenda, which is the update on the development of the Integrated Care Partnership Strategy and the role of this board. And is that you, Sam, again?
Yes, thanks very much, Chair. So if you bear with me, members, I'm just going to share my screen a minute. I'm going to take you through a few slides that I hope will be a helpful update. Okay, hopefully you're seeing that presentation come through now. So I think I'll just begin by saying I'm delighted to have been offered the opportunity to lead this piece of work, and I'll be the Senior Responsible Officer for developing the Integrated Care Partnership Strategy. I think the reason why I'm personally so pleased about this is that it offers a great opportunity for setting a level of ambition and expectation in our system as it changes. And it's a really good chance to identify the issues, the outcomes, the opportunities for integration in our system from a range of different sources that we feel are important, but also that people in our communities feel are important, that we would like to make progress on. So by getting this right, we're working in quite a different way to the way that we've developed strategies in the past. My experience previously has been that organisations tended to write strategies and then consult in a very limited and narrow way. So we'd have a technical view of what we thought was important, then we'd just go out and we'd sort of trail it through a few boards and do some public consultation on very, very set and fixed questions. That is not the intention with this process this time around. We may not get it right, but absolutely this is a chance to do some of the technical bit, and Natasha is going to talk about some of the findings from Joint Strategic Needs Assessment and Population Health Insights. But the important bit, I think, is the change in behaviour. And we would like, through this working group, to set a very different signal to the system, that we would very much like the upfront involvement and the conversation about what we think is important before we then pull the threads of that through into a strategy for the system. So I'll very quickly run through the slides, touch on the requirements. I'll sort of briefly share with you the timescale for the production of the strategy. But the slides aren't really the main story. The main story is the message that we want to do this in an open and inclusive way. And the other message is, even though we're heading for an interim strategy by the autumn, that's a national requirement because the rest of the system will then be asked to develop their strategies off the back of it, particularly the NHS Integrated Care Board. I think the point is that if we get good engagement processes underway right from the start, this should be a rolling programme of engagement. So there may be questions that come up after the first year that need a deeper conversation. And we're hoping that by setting off in the right way, we'll have the connections and the ability to be able to continue to have that conversation and to shape and realign the strategy if that needs to happen. So I'm just looking for some very quick feedback really on the questions below. Do you support this 6-month timescale? Do you generally agree with the approach that we're presenting today for how we're going to develop the strategy? For the Health and Wellbeing Board in particular, the idea is that the strategies should complement each other. So we're not asking for a rewrite of the Joint Health and Wellbeing Strategy, but we do need to see what's important to the Health and Wellbeing Board reflected in the ICP strategy. So it's an opportunity for the BCP Council Health and Wellbeing Board to say, this is what we think is important for our communities and our place, and to have that reflected in the ICP strategy. And then what we really need to do is to work on, I'm not sure I like the way question 4 is framed. I don't think it's quite right. It's not about identifying 2 or 3 questions that we need to ask communities. It's about having the opportunity to start conversations with communities and those questions may become more apparent as part of that process. I don't want it to come across as if it's predetermined. So this is a slide that just shows you the hierarchy, if you like, or the organisation of what the national guidance is saying. Health and Wellbeing boards will be asked to approve the Integrated Care Partnership Strategy, which is in the orange box, and there's a read across to make sure that we're reflecting the Health and Wellbeing strategy in the process. And then the most important thing is that there is a legal duty to have regard to what we say in the Integrated Care Partnership Strategy when we're developing the strategic plans of the integrated care system organisations, and that includes the new Integrated Care Board, which will be asked to deliver their 5-year plan early next year. So, ignoring the words on the slide, because they are quite jargony and public sector-y, it's an absolutely massive opportunity to, as I say, set the overarching framework and ambition for what we would like to see all of our organisations working on. Now, we can't have everything in the strategy, so part of this process is about understanding and identifying the areas where, by working together, we can really add the most value and make the most difference. So where I think we would like to see a different approach is to be more specific and more challenging. So sometimes strategies say very aspirational, but also quite woolly things, like we want everyone in Dorset and BCP Council to live life in the fullest health possible. But there are some long-standing challenges with outcomes in parts of our communities that we haven't shifted very far. So let's challenge ourselves to be more specific about those, let's name them, and let's use the strategy development process for being a bit more open and transparent with the public and starting to say, we're going to do some work to shift this, and you can hold us to account and see how far it's shifted as we go through that timescale. So quite a different feel. I'm personally really excited about it. I think we've got a real chance to set the right tone and the a different approach for what we want from an integrated care system, and I'm appealing to the Health and Wellbeing Board to play a full role in that. So it will be better for people being involved in having a conversation and challenging us. If you think we're getting it wrong, please speak up. So I'm just going to skip through. In terms of the design principles, just some of the things we've been thinking about. There should be a common message for our employees in the system and the public, because to some extent they are the same people, aren't they? We all live and we all work in the public sector. There is no need to have a different narrative. It is the opportunity to do things differently. It certainly isn't going to be developed in the way that some of the previous strategies have been, in just running through almost like a tick box exercise to show in your strategy that you're reflecting national and regional expectations. It has to start from building up from a good evidence base of what we know about our communities and what we would like to flag as opportunities where we could do better. If we do that in an open and transparent way and we get the co-design approach right, then I think that could be really exciting. Obviously, we're then going to get into the space where some of this is about having an honest conversation with communities, because we can't necessarily deliver everything. If we can't, we should be honest about that. But we do need to flush out some of those areas where people haven't been served as well and involve them genuinely in ideas about how we could make a difference. So it will be heavy on engagement. As I said at the start, we may not be able to finish that off in 6 months. It's not the intention for this to be a one and done process. We really need to do a continuous engagement process around this, and where there are important issues being flagged, take the time to finish that off properly. This is quite a key slide I'd just like the board to look at today. This is the planned 6-month timescale for how we intend to develop it. They are only indicative timelines. Some of these will vary, but broadly, we're in a process at the moment where we're understanding the current position. So we have a lot of technical insight and knowledge from the Joint Strategic Needs Assessment and population health management data, as well as lots and lots of insights from engagement work that's already been done. Once we've understood the current position, we'll be using that to then run a process of engagement through our boards in the system, organisations, boards, meetings throughout our system, opportunities to have conversations with the public, with employee groups. And so that's that engagement process that takes us from April through into July. And then as a result of that, we'll start to try to draw together and synthesise what we think the most important themes are. And then we'll go into the approval process in the autumn. But I'd say this shouldn't be something that sits on the shelf. It's certainly not something that we would want to see finished in the autumn and then never revisited. So one of the changes in behaviour that we'd like to see in the system is a regular revisiting. So we'll probably be using both boards to do an annual review and refresh based on the work connected with the strategy development. So I think just a couple of final slides. Those are the 4 questions that I posed earlier on. Are there any sort of early quick comments about timescale and approach? Do you broadly support the design principles? Thoughts about how we join up the ICP strategy and the health and wellbeing strategy? And perhaps I'll leave the final question because I think this needs to be surfaced from the engagement process rather than predetermining some of the questions. And then just a final set of points. Since we put these slides together, there was also the publication of the second integration white paper, which was a couple of weeks ago, and some more helpful dates here on further guidance that's coming out. So the integrated care partnership itself is to be issued with guidance in the summer. It's not going to be detailed, so we can come up with an arrangement that works best for us, which I think is very helpful. I've mentioned that the strategy is required by all systems in December. We're going for a slightly earlier time period. There will be further guidance on how health and wellbeing boards can work with these concepts of integrated care partnerships and place-based partnerships. And then the integrated care board 5-year plan is required in April 2023. So that's really the NHS part of the plan, if you like. The national guidance also says we need to have a shared outcomes framework agreed locally by April 2023. We may get to some of that in the ICP strategy, but I think as those more detailed plans start to be developed by organisations and the ICB, that's where we'll get a bit deeper into what are the outcomes that we collectively sign up to, particularly looking through the lens of place. And that chimes quite nicely with the timescale for the place-based plans to be agreed and in place by April. So I'm going to pause there for any questions, but I just urge you all to get involved, and you'll have the opportunity to do that in the next agenda item when we start to talk to you about JSNA. So thanks very much.
Sam, thank you. Are you expecting people today to come up with answers to those questions, or are we to take those away and bring them back?
It's a really good question. I think any early thoughts, I'm all ears. There'll be more opportunity to engage in strategy development. So certainly we'll be coming back to the Health and Wellbeing Board. We've got another meeting in June. I'd expect to be regularly coming to boards over the next 3 or 4 months with an update on progress. So may well be thinking of a way that people can contribute the answers to some of those questions continuously, if you like. And I know that Kirsty's on the line, and Kirsty Hillier has been supporting from an engagement perspective. It's still early days, but we're certainly providing mechanisms where people can continue to contribute on those questions.
Thanks, Sam. I've got Councillor Iyengar showing.
Yeah, thanks, Karen. Thank you, Chair. Sam, thank you for that. And of course, you know, we've spoken about this. If I may just offer something, just quickly into the board now. I hope it's the right place that I'm saying this. What's there is kind of fine. It's almost, you know, in a sense, in one mode of thinking, one can't fault it. There's sort of a step-by-step looking forward. Just kind of what's interesting in my mind is the recent past and where we've come from, and going through COVID and coming out of COVID. And if I pick the vaccination example, where Sam and others in the room, as it were, you've been intensely involved in it, and that's something where there wasn't all this build up to it. It was sort of done. Now, I don't want to minimise how difficult and how challenging and at times unpleasant that was for all the health practitioners and others involved in all of that. And you know, if that's if Mohan's referring to that as a good practice to be repeated, I'm not, because there's others probably in the board right now thinking, no, there's actually large parts of that experience we would not want to repeat going forward as we develop, our role within ICS going forward. On the other hand, though, this is where I'm just going to lobby from the off here, is there's something I think not quite right about doing such a sort of a helicopter step by step through to April 23 to create things like sort of an outcomes framework and so on and so forth, because let me be bold, I will struggle to engage with that at all. I know what one means, but I will really struggle to engage with that. Whereas if we say, for instance, how can we proceed on a basis where we don't know all the boundaries of the subject and we don't know the helicopter view in its entirety, but what we can do is we can try things using all the wisdom of people in the room and the experience in the room and managing the risks and doing all those important things and check we're not being grossly sort of unequal across BCP in this group versus this group, but take the spirit of what's been done over the past 2 years, locally, nationally, to take a bit, evolve, learn, move it forward. I'll leave it there because hopefully I don't need to embellish what I'm saying, but it's just a fundamental way forward that this board and other groups as well that we adopt as going forward with this. I do please have a concern about being very managerial and textbooky about this whole thing, because I don't think it's capturing the spirit of what we're at with this. Thank you, Chair.
I probably agree with you, Mohan. I think what you've seen today is maybe a hybrid between an expectation around a national process and a timescale. But what I said right at the start of the presentation was that our intention in the group is to behave very differently. So we always have quite prescriptive approaches that will come down through the guidance. It will say the strategy should say A, B, C, and D, and normally we go through the process of ticking that off and reflecting it in the strategy. I think the important point, and you mentioned COVID, is fundamentally we have not looked after parts of our population sufficiently, and that led to the very, very different outcomes that you see in different parts of our communities. You could see it nationally, you could see it locally very, very clearly. There were some people who were, vastly more affected by the pandemic than others. And so I think we could write the strategy very quickly. That's not the bit that worries me, but it would lack ownership and it would lack depth. So the time that we're taking is about involving people. And if we involve people, then that's creating a much more powerful case for change, I feel, than if we write something from a technical perspective. It sits on a shelf, maybe it gets forgotten about very, very quickly.
Mohan, did you want to come back in? You're on mute.
Yeah, thank you, Simon. In a broad sort of agreement on this one. It's funny, we talk about the timescales that have been laid out there, and in the meantime, I had the pleasure of listening to a presentation recently on how the facility was set up. The precursor of a health village was being set up in Beals in the Dolphin Centre in the upstairs there. Now, please, if anybody's thinking, where's Mohan going with this? It's something that's small, but something that's just fabulous, absolutely fabulous there. I mean, I don't know what others in the room think, but just goodness me. I know people have gone there, goodness me, and how quickly that was done. And it's something whereby, we'll learn from that. It's not the finished product, is it? We'll try it, see if it's duplicatable, see if it needs to be modified in its format and so on. So please, I'm not talking about one facility and one implementation there. I'm talking about a style in which we go forward with these things. That's all. Thank you.
Thanks, Mohan. Would anybody else like to come in? Jess?
Thank you. I just want to say I thoroughly support the idea of taking that community engaged approach and community led approach. I think that's brilliant. and I like what you're saying, Sam, about not necessarily just ticking all the boxes. I guess my challenge would be, is 6 months enough time to genuinely do that and do it really thoroughly? And I think you had one loop back in your thing. You're going to need a lot of loop backs, and I know you know that. And so it's just making sure, actually, if you're going to do it genuinely, co-design genuinely, we give ourselves enough time to get that really right. And the other bit, just to comment on, I think you're right, absolutely using the data to reach into those communities and hear from them that have been so left behind, that we don't yet know how left behind they are from the pandemic.
Thanks, Jess, and that's a really good point. I'm going to bring Mike in, and then perhaps you can come back in, Sam.
Yeah, thank you, Chair. I'm being parochial here. I'm just expressing the hope that one way or another we will involve our children and young people in this. Thank you.
Thank you. Is anyone else wishing to? While Sam makes notes, does anybody else want to comment? Jess, I absolutely agree with you. That was going to be my question. Is 6 months going to be long enough? Because it doesn't seem long enough. And also my concern that everybody has been obviously so focused on COVID. Is that going to sort of skew those conversations that we're going to be having in our communities? Will it all be around COVID and the repercussions that some people have suffered from it? How do we move it on so it's wider than the pandemic?
So I'll try and pick up a couple of those points. I mean, very, very quickly, Jess, absolutely agree. I think, this is about establishing a behaviour around engagement and co-production where we need to regularly revisit what we said in 6 months, because inevitably it won't be right. It'll be the first layer, probably. And as we get deeper into it, we'll hopefully surface a more effective connection with communities, but we might be talking about some very different things. So it sort of partly answers your question, Karen. It might be that the starting place has to be about COVID, because that's what people are talking about. And it's important that we start with where people are, not with where we expect them to be. And that's often where there's a disconnect, isn't there, between service and service users. I think absolutely, Mike. One of the challenges, and I'd be eager to hear for ideas about how we do this. If you look at the huge range of potential people and organisations that we could engage with, it is a vast list. So how do you do that in a way that's genuinely meaningful, has enough time to surface a depth around those conversations, that you're not just skating over issues and making assumptions? And I think what we're starting to think about is the engagement led and directed by the themes and the questions that seem to be important, or do we go wide right from the beginning and start to then focus in depending on what's coming back? So there are lots of different ways of doing this, and we're trying to think about, probably there will be several parallel engagement processes going on at the same time, and we're going to need to draw on all of the engagement that's happening, because I know there's lots of stuff that's going on that we're probably not aware of. So how do we make sure that we cast the net far and wide? People have got the opportunity to say, I think that this is really important over here. You've missed this conversation. Let's not overlook that. But equally, we need a process for being able to synthesize it, because we can't do everything. It's got to be focused, but at least let's start off by not trying to miss important things. I think that was all of them.
Thank you very much, Karen. Absolutely fantastic, Sam. This is brilliant. Great to hear that this kind of investigation or data gathering is going to take place. As you said, it's really, really important that we make sure that we're using the right language, we're going to the right places, using the right media, all those sorts of things to really get to people, to those people that are often left out of this kind of conversation. And I think it's going to be quite interesting to try and find people like Community Action Network. They're going to be great because they have access to those different groups. Parent carer groups, they represent quite a big cohort of people who have really strong ideas and experiences. So I think those sorts of people are going to be really important as well. And so just getting people involved and getting them interested and making them feel that it's worthwhile to spend their time responding to these kind of questions. It's going to be great. As you know, we're pursuing an asset-based and strength-based way of working. Our new colleagues here are going to be, really important on the ground, actually, gathering that data. And of course, I mustn't forget the people who are sitting behind me here, because they're going to be listening to those kind of lived experiences very soon. And, and civic leaders will be listening and responding to that. So there might be quite a lot of input from there. Thank you. Yeah, thanks, Jane. That's actually really helpful. Son.
Yeah, I was going to say, I'm part of there's actually a work stream through the, specifically to do with engagement for the ICS. I just wonder who in the room, I know Kirsty who's on Teams is sort of heavily involved with this as well, but I've been involved with it too. I just wonder how many other people in this room here are actually even aware that that's happening, because it's specifically to do with engagement.
Kirsty, did you want to come in and comment? Because we've had our first meeting this morning, haven't we? And you've got plans.
We do, absolutely. And thanks for mentioning that. So we've got a really extensive engagement network across the whole of our system, involving all of our statutory partners, community and voluntary networks. So there's representatives from all of our organisations. And one of the key things that we want to do is pursue the idea of having over 100 conversations with all different people from all different areas across our community. So that would include young people, homeless, adults with learning disabilities, people from minority communities, and reaching out through those voluntary and community sector network partners to help us to do that. That's one of the exciting and different things that we're looking at doing this time around, and all of our engagement leads are all very much involved in the process, and we've been starting to sort of shape how we might achieve that, and very much over a much longer period of time. So absolutely, that's something that can't be done within the 6 months. It needs to be iterative, needs to evolve. Every time we have those conversations, it will feed back into the plan so we can adapt and change to the needs of our communities and people. Thank you.
Sorry, so I thought you were going for your microphone to come back in. Thanks, Kirsty. That's actually really interesting, isn't it? And how are you going to engage with people? Are you going to, what methods are you going to be using?
So the idea would be to have these interview interviews with people. So really in-depth conversations. It's not quite an ethnographic study where we go and live with people for a week to really understand what their day's like, but really to have those long conversations, chat to people. What is it like to be you for a whole day, from when you wake up to when you go to bed? What are the barriers for you to be able to live a healthy life? What can we do to support you? What can you do to support yourself? So those are the sorts of conversations that we want to have with as many people as we can through those networks, and then pursuing all different other methodologies about how we could gain those insights. People have already touched on an awful lot of work has happened over a number of years with engagement exercises, and so we've been over the summer compiling all of the insights and learning from those to feed in at this early stage to give us time then to have these really in-depth conversations to take us forwards.
I really like that. And as Sam said earlier, it's not a tick box exercise, and that certainly isn't, is it? It's something very different. Yes, that's I'm really looking forward to the outcome from some of those conversations. Yes. Anybody else wishing to comment? Any more questions? Well, I think we've put a comment in the chat bar. All right, yes, about the ABCD principles, individual outwards rather than services. Yeah, absolutely right. Yes, thank you for that. Okay, Sam, I think what would you like this board to do? Would you like us to come back?
I think we will regularly engage with the various boards. So as I said before, you can expect a bit of an update in June. At this early stage, I'm just really seeing if there are any concerns. I've had some very, very helpful pointers from the conversation this afternoon. What we're really just looking for is the kind of, yes, you're going in the right direction at this stage. And if we start going off course, please let us know and continue to correct us. We will be, I think, able to offer a much more clear timetable of opportunities for how people can get involved. So once that material starts to be produced, it'll be easier and clearer to see how different groups can have their opportunity to take part and have a say. But yeah, it's been really, really helpful. And if you've got questions that occur to you after the session today, you've been involved in a piece of work where you think, actually, we really need to have a conversation about this with our communities, please, we're all ears. We're sort of in listening mode. So do forward any suggestions or ideas.
Yeah. Okay, that's great. Thank you, everybody. Right, moving on to item 10. And I guess that's you again, Sam. Is it summary of the GSNA, Joint Strategic Needs Assessment?
I'm going to hand over to Natasha, who's going to take us through this.
Thank you, Sam. Just going to put some slides up. And I'm hoping this session could be interactive as well. So giving myself enough texting, I'm just juggling tech. So, present mode. There we go. So hi, I'm Natasha. I'm coming to talk about the Joint Strategic Needs Assessment update. What I would like to cover today for the board is just a little recap of the JSNA process and the work that we've been doing. I want to talk about a proposed update to the format of the narrative that comes out of the Joint Strategic Needs Assessment. And then hopefully we've got time to have some discussion around the outcomes and areas of concern for BCP. So just a little recap of the, I'm going to call it the JSNA. The JSNA is a statutory requirement for ourselves to go through a continuous process of strategic assessment and planning, with the key aim being to identify priorities for health and wellbeing. The key purpose in the guidance is to support the identification of health and wellbeing priorities that feed the health and wellbeing strategy. However, the JSNA's got a lot of other uses and potential, so it provides an evidence base around health and wellbeing and drawing out those needs and priorities. So it's therefore useful as narrative on priorities and evidence for inclusion in other strategies, as Sam just talked about the ICP strategy.
The slides aren't moving on.
Oh, okay.
In the presenter mode.
Sure. We're doing it straight off. Wait, live, maybe that will help. Just loading. Coming through. There we go. There, finally. Yes, so as I said, it also provides that evidence base. So we've got the JSNA website with all of the data and information and needs assessments on that. And I know people find that useful when they're putting together funding bids, for example. People use that as a evidence base to support their projects and programs. It's also useful at that service planning and commissioning level because we do deep dives into topics and an opportunity to look at some key issues and questions. The next slide. Excellent. So the JSNA includes many strands of insight, and we've been really working over the last couple of years to develop that picture. There's kind of no guidance on what a JSNA should look like. Traditionally, it's very data-driven, looking at needs assessments and chapter type approach, which we do look at data. But I think we've taken some value in the wider insights that we have. So talking to people who work directly with communities, what kind of issues they're seeing, doing participatory workshops with stakeholders around specific topics. So I've talked about previous topics we've done around falls, emergency emissions, armed forces, etc. So we're trying to build that big picture of need, looking at data and insights from across our system, as well as breaking it down into geographical areas. So we've got locality profiles and other profiles available. So all of that we've pulled into an annual thematic narrative, which is basically telling the story of what are the strategic issues for BCP in regards to health and wellbeing. I'm going through the process at the moment of updating the narrative for this year, and we'll be bringing that content back to the board. But I really wanted to get your input at this stage on the proposed structure for the update, and then in the second half of this presentation I'll share some of the themes that have already come out so we can have that discussion. So we're proposing that narrative looks at three areas. Firstly, the health of our communities. So this would be looking at key population health outcomes and inequalities of concern. What's coming out of the data? What can we see from what people are telling us that is of concern for BCP? Secondly, we'd look at health and care themes. So looking at any trends or variation in conditions and ill health, specifically diving into that management of conditions and support for ill health. And the third element we'd like to bring in is looking at integration opportunities. So from what people tell us from the interviews we've done and the panel workshops, what are potentially drivers, good opportunities, good examples of integration, and what possibly might be barriers in our system to good outcomes. So really exploring some of those themes. Hopefully that's going to move on. So hopefully, I think everyone's got devices in the room. What I'd like to do is use Slido to collect some feedback from everybody. So if you could go to slido.com and just enter the code BCPJSNA. I will put a question live. Sorry, what was the code? BCPJSNA. Just share it up on the screen.
Has everyone managed to log on to Slido?
See, people are adding their votes. Just need to log in. Yes, that's the first question. So from the first question, just a sense of from what I've just shared around the different avenues of data coming in, just get your first insights into what you think the completeness of that process might be. Just to test out the Slido. I'm not able to present.
Mike, you're looking slightly puzzled, and I'm feeling slightly puzzled too.
That's fair enough. No, unfortunately, the template didn't include don't know, but that is a good point. I should, yes, feed it back to the developers. I'm going to stop trying to share that screen because that's not working, but I can see it on my phone. So we've got in the 6s to 8s range and a few lower down. Excellent, I can see more people coming in. So that is changing. Great. 9 votes, so fairly in the middle. Thank you for your feedback there. And the next question I'm going to put up is, how do you feel about the 3 proposed categories? I'll put them back on the screen for you. So we're proposing to show the data and insights in that document into 3 sections, looking at our health of our communities, looking at care and health pathways and themes, and integration opportunities.
Natasha, can I just ask a question on that? Who came up with those proposed categories? And why? And why were those 3 chosen?
Yes, sure. That's something we talked about in our development in my team, just trying to group some of the breadth of the insights, but I'm welcome feedback on those. I'm just trying to ensure that we cover the whole picture of health and wellbeing needs. So looking at health in general and population health outcomes, that might be things like life expectancy, healthy life expectancy, deprivation, and then the health and care themes would dig a bit deeper, looking at conditions. And I think personally think it's important to look at how the system interacts with that, and that there's lots of useful data and insight around what people see as useful things and maybe barriers to how we work and support people. But welcome thoughts on those 3 categories. Jess.
Thanks, Chair. Is there anything that you thought of that you decided not to add as a category?
I hope we captured everything. There's nothing we excluded, but I'm keen to see if anyone thinks there's anything missing.
Yeah.
So I think
Sam,
what we're trying to do is this session really connects with the previous session a little bit, and we've talked quite a lot in the previous presentation about the importance of engagement. This is almost the technical bit, but what it's really important that we have a view from our boards that are sort of leading our places, if you like, in the BCP Council Health and Wellbeing Board, because JSNA is a statutory duty of the board. What we were trying to do was to frame the output from this board in a way that we think gives some quite clear signals to what the integrated care partnership strategy should be focusing on. What we don't want is a return to what we used to have, which was a huge data directory in some cases of lots and lots of health facts, but it doesn't really give planners or commissioners much to go on. So grouping it into a narrative about the health of our communities, and particularly where the health and wellbeing varies significantly, and then providing some commentary on the health and care themes where we think improved quality or a change in the way that we use our resources could improve outcomes, we think is really important, because at the end of the day, the task of the integrated care partnership strategy is to provide a framework for health and care planning. And then the final bit is integration opportunities. I think that's a bit more of an open commentary, where we think that services are not working closer together, because that comes through time and time again. Natasha talked about some of the panels that we've done on quite varied topics, from looking at the Armed Forces Covenant, care that ex-services people receive locally, all the way through to conversations with families who have children with additional educational needs. When you boil it down, people are quite often saying the same thing. You know, people don't listen, there's never enough time. I keep saying, you know, things that are important to me, but they're never reflected in the information that's collected. And just this idea of, it's far too easy to hand people off in the system, isn't it? If you're just there because your hand's hurting and no one else is commenting on the fact that you don't seem to be looking after yourself, or you may be struggling in a, you know, in a bigger way, it's not good enough just to say, well, we're not going to deal with that today, your hand's better, I'll see you later, good luck. I mean, obviously I'm paraphrasing and that's simplistic, but sometimes people are left with the sense that they do get passed around and people don't listen.
Thank you, Chair. What comes up for me from that is actually, should we therefore have on here what the barriers to having healthy communities are? So I guess where I'm coming from is I'm thinking about the JNSA is very important when I think about operations across BCP, because it's really important to inform our local plan, it's really important to inform our local transport plan. It's very much in that space how it's going to inform and shape our thinking and our policy around place, and around that sort of prevention and early intervention space. And things that help inform us often when we look at what are the barriers, and therefore what are we doing that's causing a barrier, and what can we do to unlock that.
Thanks, Jess. I've got Rachel.
Thank you. I was going to say exactly the same as you there, Jess. Having used in my previous roles the JSNA a lot, it was very much data-driven and very dry and very bland. But these themes and these headers, to me, feel much more informative for us trying to decide what direction to take our services in.
So Sam, and Natasha, we're obviously doing the Slido, but that's not what you want from us, is it? You want the narrative around
yes,
those themes to come from this forward. So it's not a question of just ticking a slide and then moving on to the next one. You want to hear more from us.
What I'm going to do is tell you a little bit more. That was just the starter.
Okay.
So I'm going to drill down into a bit more detail now. So just to share with you how those themes might work, and also some of the themes and issues that we already see and we already know about. So if we take health of our communities and look at some key health outcomes of concern, if we take life expectancy at birth, apologies, that looks small on that screen, but it's the picture you want, not the numbers. So we know life expectancy data gives us a snapshot of mortality of those living in an area at any one time, and it reflects a lot of different aspects behind that. So the risk factors that people might have, the prevalence and severity of disease, effectiveness of interventions. There's a lot behind this really big overarching indicator. And for BCP, generally, when you look at indicators at an overall level, we do pretty well compared to the England and national averages. However, we do see variation. So what you can see on this slide is the life expectancy by deprivation. So at the top is our most deprived decile, going down to our least deprived deciles at the bottom. And you can see the variation there. At the top in our most deprived deciles, we have shorter life expectancy. It's roughly about 10 years difference for both males and females. So that's a decade really difference in life expectancy. If I move on a slide, playing ball. If we look at healthy life expectancy, again, we're looking at the shape of the curve here. So this is national data. Unfortunately, we don't have local data broken down, but we know that there is also variation in the healthy life expectancy. So this is the period of time that people live in good health. And what we can see is in our most deprived deciles, people live in good health for a much shorter amount of time than those in the least deprived deciles. So they start to develop long-term conditions from about early 50s in our most deprived areas, whereas in least deprived areas, you're looking early 70s before you start to develop long-term conditions. So quite a significant difference. In the most deprived areas, you've got people living shorter lives, but also getting conditions a lot earlier on than people in our least deprived deciles. And that affects quality of life, but also affects the amount of care and support that those people need. And as they go through life, develop more comorbidities and complex needs. So I think it's a really important indicator to look at in understanding health. If we look at some of the indicators underneath that, we know there's certain issues in BCP that are of concern. Generally, health is good, but there are some areas that could be better. We know that we've got children who are affected by income deprivation, and that varies by geography. The map there shows the deprivation deciles in relation to income deprivation and the areas where we have more children living in income deprived households. We also know we see issues around obesity. That's very prevalent in both children and adults. Emotional health and wellbeing is an issue both in children and young people and adults. Housing is really important in health and wellbeing. We know BCP is a very desirable area, but with that comes housing affordability issues, and we have one of the highest housing affordability ratios locally in the southwest. And some of our homeless indicators are performing worse than the national. So there's lots feeding into that picture of the health of our community. If we take it down a level to look at what health and care themes might tell us, there's a number of conditions where we see variation. I'm going to pick out coronary heart disease as an example, which is the map we've got on the screen. And you can see the variation by area there of mortality for coronary heart disease. But we see that in other conditions as well. Quite often correlated with our areas of deprivation, but we also see variations in gender and other socio-demographic groups. A second condition I'd like to point out is hip fractures. We did a panel workshop on hip fractures and frailty, and it really brought home to me the importance of that in people's lives. So if you have a hip fracture, around 1 in 3 people return to their former levels of independence. So 2 out of 3 have some impact on their quality of life. They might have mental health issues from pain or reduced mobility. They might even have care support needs and needs that higher level of care support. And really in frailty and hip fractures, what people told us was it was all about trying to prevent getting to that point as much as we can. So building in prevention to stop the cycle of falling and having injuries, because at some point, once you're in hospital and have that frailty, it's quite difficult to try and reverse. And so it really highlighted the importance of prevention in that conversation. Hopefully that leads to the third slide. So this is talking about the integration opportunities. So these are just three things that are quite often talked about, I think, in pretty much all of the panels that I've done and interviews with people working directly with communities. The first thing they often say is that issues never arise on their own. It's never just one thing for people. You can help people to try and stop smoking, but actually, if they're going to lose their house in a couple of days, or they've got really severe financial issues, then quitting smoking is desirable, but not at the top of their priorities at that stage. And there's lots of examples of people talking about how people have complex issues. You often see mental health issues coming alongside financial issues, for example, or substance issues. And actually people talk about how effective support needs a holistic approach so that we can build resilience for people rather than reliance on a service. And so that's a really strong theme that often comes out, is this holistic view. The second one, which has already been touched on today, is around communication and engagement. So something that comes out quite strongly is the desire to work with and listen to our communities and really understand their needs, and to work with communities in a way that encourage engagement and collaboration, and utilising community resources, recognising the role of those assets. And that brings us on to effective collaboration. So again, something that often comes up as a potential barrier is inter-service or inter-organisation relationships and how well we can work together. And that's seen as a really important thing to help us manage demand for services. It's working together better. People talk about partnerships between organisations, but also between communities, volunteers, residents, for example. And there's lots shared about good examples and what good looks like. Generally, that tends to come out as you need both the strategic level buy-in and processes for collaboration to happen, but also it's really important to have trusting and communicative relationships on the ground as well, and where people kind of give examples of it going not so well, there's usually an issue in one of those two areas. So that's a bit of an overview of some of the themes that we already know about and things that people tell us. What I'd like to do is turn it over to you now. I'm going to put another question live. This is so I just can capture some of the content and get people's ideas flowing. But I'd like to open up to the board. Firstly, what outcomes or service areas or issues do you think are of concern in BCP? Do you want one or more than one? You can put more than one answer down. I will try and get it up on the screen while everyone's typing away. Okay, hopefully we've got that up on the screen now so you can see the comments coming in. I think with Slido you're also able to upvote any ideas? Great, so I can see lots coming in. The screen's not quite tallying up with what I can see, but I'll read them out from here. Talking about taking action on health issues for priority communities, drug-related deaths, inequalities, and looking at going further to understand why not everyone engages. Loneliness and isolation is on there as well. It's a very important issue. If anyone wants to come in on the microphone and discuss as well, then that's welcome.
Chair, can I just highlight that I think there may have been some issue with actually viewing the presentation live. So if you can provide me with a copy, and if it does then require a copy, then obviously I can provide it to them.
Sure,
Just to
not a
highlight.
problem.
Thank you.
Several comments about health inequalities coming up. Mohan, did you want to come in at this stage?
Yeah, thank you. Can I ask, this exercise, we're polling ourselves in the room here on this question. Do we, with respect, do we know the answers to these questions from various pieces of work that either public health, CCG, NHS, and even the local authorities have done in the recent past on this? Because I'm nervous about giving my view, because it's just my view from my ivory tower as to what I think the issues are. I don't think my view should carry so much weight, actually. But do we not know this from our own going out for many years into communities, locations, to understand this picture?
Well, can I just say, I think any ideas and thoughts that you have, I think I'd really like to hear them. We've been talking about prevention at scale at this board for a long time, and we still have a lot of the same issues, but then who could have foreseen the pandemic and the effect that would have? So I think if you have got something you'd like to say, I think all contributions are really valuable.
So, if I may, Chair, it's meant constructively. It's only that, you know, I could put quite a list of things here which, you know, of concern, health and well-being related. It's more sort of a question about, right, you know, we're polling this group here now. There's many groups we could poll around BCP and ask the same question. Do we not have the analysis from before as to what the answers to these questions are? What are the most recurrent, you know, most sort of gripping, most sort of, you know, preoccupying things that we need to address in health and well-being? Do we have that information already?
I think the answer is mixed. I mean, there will be some where we've got very, very good evidence, which is supported by data. But if you think back to the way that we're trying to present this under the three headings, when we're asking a question about opportunities for integration, I think that's a bit of a softer question, isn't it? So this is trying to draw on the experience of board members and connection with the organisations represented on the board as to what are they aware of that people say might not be working for them in terms of how we work together. So you're right, there's an evidence base for some of it, but some of why we're asking these open questions is to tap into the knowledge and the experience of the board.
Well, was that okay? Did you want to share, or did you want to put it into the Slido?
So I was muted. That was fine, Karen. Thank you. I'll put something in. Thanks.
Okay, I can see lots of ideas coming through. The last question I was going to pose to the board was, are there any integration opportunities that you think should be highlighted? I mean, I've obviously pulled out some themes from the data and can look at feedback, but I welcome input from the board and the board's views on if we're building a narrative about BCP and the issues, what opportunities or drivers or barriers do you think should be highlighted from your experience? Is anyone coming in on that question? I've added it on Slido, but feel free to come in and discuss. Steve, did you want to come in at this stage?
It was only. It was just. I'm just looking at that question. And I'm not quite clear what you mean by integration opportunities. Integrating of what to do what.
I'm looking for insights and the board's view on what if there are potential opportunities or issues around. When we're talking about integration opportunities, it's around that theme of how we work as a system, what issues we could maybe tackle together, how we might do that, what barriers we might have. I'm interested in the board's views to add to the insights we've already got.
So does that? So you mean you're looking for ideas about how different, I guess, different sectors or different delivering services could work better to help address health outcomes?
Yes. Yeah, welcome all ideas and comments. Is that okay, Steve? Does that answer your question?
Yes, it does. Thanks.
Great, thank you. And Louise, did you want to come in?
Thanks, Chair. I think to follow on from what Steve was asking, so as I understand it now, I think that involving the voluntary sector more would definitely help. And I often think with the JSNA that the data is incredibly useful, but it only tells one part of a story. And so your approach is really welcome because you can have the data about, you were talking about life expectancy, but unless you're talking to people and those communities in the areas that you've targeted as having lower life expectancy, then you don't really understand what could change that. You can come up with ideas about what might improve it, but without talking to people and involving them in the process, then you're never going to really change anything. So in terms of integration, I would say, yeah, more involvement from the voluntary and community sector. And I welcome the approach of involving people and kind of balancing out that data with real life stories.
Yeah, thanks, Louise. That's a really good point. Thank you. I can see lots of comments coming through, so thank you. Apologies, the tech doesn't seem to be syncing. But you can hopefully all see that anyway on your devices and through the link. If there's no other comments, then are people still typing? I'll leave it on if people want to. Yeah, if you want to add anything, some great idea just pops into your head, that would be very welcome.
Thank you. We've got some really good comments here, I think, haven't we? Probably nothing's a great surprise.
Thanks very much, Chair. I think what we were aiming to do from this process today is it's not about finding the answer. It's interesting to hear some of the questions that people have posed about why are you asking us this and what are you hoping to gain. Sometimes our experience is when you come to a board and you run through a whole load of technical issues identified from the data, it's tempting just to let the presentation go by and not take part in it and not engage in it. So what we're trying to do is to have a bit more of an active participation in the board, even if we don't know the answers. Let's start to engage in some of the questions. And we're really just asking for signals back from the board about some of these issues. We can test this, we can test it with data and evidence, but we can also test it with people and communities. You know, I think Louise's point is absolutely really well made. You'll only get part of the picture if you're looking at the patterns supported by the data. Actually, we need to learn more from people's experiences and listen to what they've been saying, because the solutions may well lie in what people have been telling us. And sometimes that, you know, that can be quite uncomfortable from the way that we've worked. So.
Yeah, thanks, Sam. I think you're probably looking for a bit of challenge as well. You're not expecting us just to kind of agree and then move on. You want to hear what we genuinely think the issues are and where we get it wrong. We're not going to have big solution necessarily, are we? But we can certainly flag it up. I think that's important that we have that confidence at this board that we're able to do that. Just one thing that just occurred to me, Sam, we've got the fuel increases coming along. So when we're talking about poverty and we're talking about people being in cold homes, that's going to get worse, isn't it? Is that an area that we should be focused on in this board, or is that somewhere else?
I think inevitably you have to take it into the overall context of how people are living, aren't you? It goes back to Natasha's point. You know, sometimes, again, it's a simplistic example, but if you're nagging someone to give up smoking when they're on the edge and they're living in a very financially precarious situation, you're not going to necessarily be in the right mental space to sort of go forward with that. So absolutely, understanding the context of people's lives and how they're changing is going to be a real concern. I think what is important is understanding where we can act and where we can make a difference. So it's not just about understanding who's in need, it's understanding what we can do about that. So what is the capacity to benefit if we used our resources differently?
Sam, because we've got a few new members on this board, would it be helpful to kind of put together, I'm not asking for War and Peace, but a couple of sides of A4, which just kind of sums up the themes that we've been hearing about today that we can circulate. And there might be some, are there any published papers out there that would be helpful that could perhaps be attached? Yeah. Thank you. If we're finished on this item.
I think Steve's got it.
Oh, Steve, sorry.
Thanks, Chair. It was just, I think, to carry on that conversation with that Louise started off, which is because I did hear at the beginning when you talked about the data collection that actually you are going to be looking at qualitative stuff, because just as important as the stats around people's health is actually their what they feel about their health. It can have just as much of a determinant on what they do and how they act and so on. And that links up, I think, with what you just said, Sam, is that, you know, okay, you can point to people about their smoking or their drinking or their exercise, but actually, if that's not important to them at the time, then you're probably, you know, flogging a dead horse trying to get them to change their behaviour. So, you know, I hope that the JSNA is going to put just as much emphasis on the sort of qualitative stuff around what people feel about their health and what's important about their health, as opposed to just being the good old stats from the GPs and the hospitals around the things like blood pressure and BMI and whatever we can come up with and looks very nice in big flashy pictograms. Is that we need to be able to harvest that. And I think that links go back to the ICS, this idea of having deep dive conversations with people so that actually it puts some flesh on the bones about what people feel about their health and what's important and what they would like to change.
Yeah. Thank you, Steve. Anyone else? Right, I really want to hear from the Poverty Truth Commission, ladies. So is it Emily, you're going to present to us? Thank you.
I am. Thank you very much. Thank you very much for inviting us to chat with you this afternoon. We're really grateful for the opportunity. So you may be aware of the fact that there is a Poverty Truth Commission is being established across the Bournemouth, Christchurch, Poole conurbation, and we are going to fill you in a bit on that. So my name is Emily. I'm one of the co-facilitators within the Poverty Truth team, and I was part of the startup team along with a number of other people as we brought this idea to birth. I'm also the director and founder of Courage to Thrive, which is a community interest company locally, which is acting as the host organisation for the Poverty Truth Commission. Angela will introduce herself in a moment. She's our project coordinator, and she'll introduce herself and mention we've got 2 other members of our team, so she'll fill you in more in a moment. What we're aiming to do with the time we have now is really to share with you the whys, the whats and the hows of a Poverty Truth Commission, so that you are informed and can understand what's happening. We hope that you will then get the value and why we're excited about Poverty Truth and just how much it ties in with so much. I mean, the number of themes that you've been talking about this afternoon that are just direct tie-ins with what we're exploring. And particularly for you to work out, I'm really hoping, again, this isn't a passive opportunity for you, but for you to connect with how does this intersect with your work? What's relevant to this for your organisation, for this board, for your colleagues, for people that you know that could be involved in the Poverty Truth. So hopefully you're going to get the whys, the whats and the hows and opportunity for some questions. So I'm going to kick off with some of the why and a little bit of the background. So back at the start of 2020, a number of us who were working in different settings locally where we could see some of the impact of some of the statistics we've been looking at this afternoon and some of the impact of the injustice of poverty playing out. And particularly where we've been privileged to get to know some of those people very firsthand who are struggling against poverty on a daily basis and hear their stories. And that group of people that have been listening to that, we got to a point where we were just so deeply frustrated that the status quo just isn't good enough anymore. And I'm sure many of you around the room from what we've been looking at this afternoon would be echoing the same thing. And something needed to be done. Now that was pre-COVID, and of course, as we know, COVID has massively exacerbated and amplified the inequalities and the poverty that we're aware of. As Sam said earlier, we've not looked after parts of our population adequately, and we know that even better than we did when we started out on this process. That bunch of people that got together had been, a few of us had heard for a while about Poverty Truth Commissions that were running in other parts of the country. And we started asking the question, might that be a helpful thing to bring to the Bournemouth, Christchurch and Poole conurbation? And so early in 2021, we set up meetings with a broad range of local leaders and grassroots representatives to explain what a Poverty Truth Commission is, which I will explain to you, and we'll have a video that will explain that in just a moment, and asking the question of that group of people, is now the time to bring a Poverty Truth Commission to the conurbation? Would this intersect with your work? Does it make sense? Would you welcome it? It's no good if it's just a bunch of us going, we think this would be a good idea. And we got a really overwhelming and resounding yes. And a number of you in this room were part of that process, and there may be an opportunity maybe to hear back from you towards the end to hear why you responded positively. So what is a Poverty Truth Commission? If the tech works, we're hoping we have a short video which we can show you. It's 3 or 4 minutes long, and it will say more succinctly than I can what a Poverty Truth Commission is. So Angela, if we get that working, that'd be great.
Shall I let it run in the background while you do a brief?
Okay, so you have the pictures and I'll give you some words. So a Poverty Truth Commission starts with a question. I have seen it a number of times actually, so maybe I know how it goes. Well, it starts with the belief that nothing, basically all social change that has happened. So these are examples of suffragettes and all sorts of different social justice issues around race and LGBT issues, where they're going to make lasting social change. It needs to have those who are at the heart, who experience that at the heart, so that nothing about us without us is for us. So a Poverty Truth Commission begins with exactly that, and it brings together the images here are people on the left-hand side there are people who struggle against poverty on a daily basis, and then you have the local leaders on the right-hand side there who are the people who like yourselves.
So sorry to interrupt, but apparently the people who are dialing in are not getting any of the sound. So I'm just going to suggest we adjourn just for a couple of minutes and just see if we can get the sound sorted out and start again.
There's no sound in the video, it's just Emily talking through.
But just to clarify, I think those people that are joining the meeting remotely are unable to hear at all, even what Emily's saying. So we just need to make sure that we can rectify that because we've got a live broadcast going. So if you can bear with me.
Poverty Truth Commission starts with an understanding that lasting social change happens when those who experience a struggle participate in generating change. This principle has been seen throughout history, from civil rights to suffragette, from LGBTQ+ issues to the disability movement. And it's the principle that Poverty Truth Commissions are founded on. Nothing about us is for us. Poverty Truth Commissions start with people who know what it means to struggle against poverty. But they are not alone. The proverb that says, if you want to go far, go together. So a commission seeks to build relationships between people struggling against poverty and people in decision-making positions in civic institutions. Over time and together, they learn about the complexities of poverty solutions. So what does a commission look like? A poverty begins by bringing together a group of experts through people who have faced the struggle against poverty in their own lives, usually around 12 to 15 people. This group spend time together, sharing stories, listening to one another, and building relationships. Doing this together grows confidence and builds solidarity. This phase culminates in a public event where these community commissioners collectively present their stories. This public event is attended by the civic and business commissioners, who are senior leaders from across society who have agreed to take part. Following the event, this whole group of 25 to 30 people form the full commission. A Poverty Truth Commission is not about the civic and business leaders or community commissioners fixing issues on their own. Instead, it is about building relationships of trust so that difficult conversations might happen. Learning to listen to one another is crucial. Listening beyond words to connect first and foremost as human beings. Together, to identify issues and begin to experiment with solutions. It might be about service design, policy change, awareness raising, building wider relationships, or many other areas in which the group together have the ability to act. The changes may appear small, but the learning and impacts are significant. Commissioners take new perspectives into their communities, organisations, and everyday lives. This creates the longer-term impact. The Poverty Truth Commission gets beyond the stereotypes of suits and scroungers. It's no longer them and us, just a bigger us. A bigger us that when it comes to tackling poverty can say together, nothing about us without us. Find out more about Poverty Truth Commissions, hear stories and experiences from different commissions, or to discover what is involved in running a commission, visit the povertytruthnetwork.org.
That tells you a little bit, sums up quite nicely what a Poverty Truth Commission is and how it works. And we're going to explain where we're up to locally with it. I just wanted to pick up on a few things that mean that a Poverty Truth Commission is a very different kind of approach. And it's been coming up with a number of things you've been talking about this afternoon. First of all, it begins by acknowledging that there are two types of experts when it comes to understanding and tackling poverty. There are the professionals, people like yourselves, who are, understand the policy and understand the structures and the managerial side of things. And then there are those who are living on a daily basis with the struggle against poverty. And the idea at the heart of a Poverty Truth Commission, and the first Poverty Truth Commission ran in 2009 in Scotland, and there have been quite a number of them that have run mainly across the north of north of England, and this will be the first. This is the first one on the south coast. The key idea behind it is the question: what could happen if we could find ways to bring both of those types of experts into the same room in a way that genuinely enables both parties to contribute to finding solutions to the wicked problems that we know have their roots in poverty that we've been talking about this afternoon. So that's exactly what a Poverty Truth Commission seeks to do. And there are a number of key differences that make that it's that phrase, what makes you genuinely able to hear both sets of voices. And the way a Poverty Truth Commission does that, which is different, is it first of all, it begins with the community commissioners. So the community commissioners are the people who experience poverty and know what that struggle is like. And they're the ones who begin by defining what the issues are that they want to tackle. So I'm talking to you as the Health and Wellbeing Board. There are going to be overlaps with health, but it may not be. It may be that health's not the main thing they're talking about. There's very likely to be elements around health and mental health, physical health and mental health. But it's up to them to define, and we won't begin by defining what the issues are. So they'll tell us, and it will be from that group of people and the issues that they point to. That's how we will then find the civic and business commissioners, who are the equal number, as that video was explaining, of local leaders. And those will be people who hold power and authority and decision-making capacity in the areas that we will be focusing on. So that's the first difference. It begins with them and they define what the issues are. The second difference is that the civic and business commissioners, so the leaders, are then invited into their space. So that makes it a very safe space for them. A space like this can be very intimidating, can't it, for people who are not used to being in it. So we will then facilitate all the meetings in ways that makes everybody comfortable, but they're coming into the community commissioner space, not the other way around. And thirdly, a Poverty Truth Commission works out of relationship. It slows everyone down. We were just talking about whether 6 months was long enough. It's really to slow people down, to genuinely see people as real whole people, and really listen, and not just see people as representatives of a certain issue, but to see this person as, Sarah, Joe, whoever it is a very different approach. And finally, once that deep listening and relationship building has happened, rather than the professionals then saying, thank you, we've heard your ideas, we'll go away and put that into practice. As the video explained, it's a matter of bringing both sets of experts together in ways that they can co-create the solutions together to the issues that have been raised. So that gives you a little bit of explanation and understanding of how and why a Poverty Truth Commission, why we're bringing one to the BCP convention. And I'm going to hand over to Angela to say specifically about where we're up to in our context and what's going to be happening over the course of the time.
Thanks, Emily, and thank you to the board for inviting us here today. Let's hope this little bit of tech works. Okay, so just to introduce our team to you today. So you've heard from Emily Bradbury, and I am Angela Fendley. I'm the project coordinator. Emily is one of our co-facilitators along with Daisy Carr. So they're the people who are hosting these meetings, as Emily has described. And then we have Catherine Harrison, and she will be primarily looking after our community commissioners. So we're a part-time team, we all work part-time, and approximately we do about 45 hours a week between us. So that gives you a scale of the project. It's the equivalent of, say, just over one full-time person over a year. And the project has been funded to support the commission and these commissioners to run for 2 years. And that's come from a number of sources, primarily, or namely through Public Health Dorset, the Talbot Village Trust, and the Poverty Truth Network. So I'm just going to run through our timeline. So the project runs over 4 phases, over 2 years. So Emily has explained a little bit about our startup journey. and about this establishing a need for a Poverty Truth Commission in the area. And it's really interesting to see Natasha's health indicators earlier, you know, about the poverty in the area. You know, we know about these areas of deprivation, and we understand that we have around 16,000 people living in that top 10% nationally of the deprived areas. So during that time, in September 21, BCP Council passed a motion to support the setting up and the delivery of a Poverty Truth Commission in the area. And we believe that it aligns well with the Council's asset-based community development, the ABCD approach, and also the existing work of the Health and Wellbeing Board. And it was really interesting as well to hear about the integrated care partnership earlier from Sam, and the way that you're going about that, because that aligns really well with the way that we're running this Poverty Truth Commission. You know, the co-designing with the communities, doing things differently and taking the time to listen to people. So we're also pleased to see that the Council has recently agreed to uphold the 6 principles of the Marmot report, and the Commission will certainly feed into that as well to address health inequalities, particularly by supporting commissioners to have control over their lives. So we're now in phase 2 of the project. In November 2021 was when the team were appointed, and we're now in the phase of recruiting those commissioners. And we're doing that through established community connections and lots of cups of tea. And we've been warmly welcomed in places already. There's been really enthusiastic support for what we're doing, what we're aiming to achieve. And we already have, we're pleased to say, about 8 local people who are putting themselves forwards to be community commissioners. But as you saw from the video, we are looking for probably at least 15. So we're still looking for those people. And what is it we're asking them? We're asking, have you had enough of not being heard? You know, that's the main thing. These people, we really want to listen to them, the people struggling against poverty, and to give them a voice so that they can be involved in influencing decisions, policies and systems which affect them. So the community commissioners, they're people who are at the sharp end of poverty. They must be willing to share their story and listen to others. We'll be providing support and training to help build their confidence and their skills. People who would love their voice to be heard. They're frustrated and angry and want to see a change in the system. And we're keen to hear from people who not always make themselves heard. So there's the quieter voices in the room. And they must be people who have the time and enough capacity and stability in their life to commit to the whole process. So we're looking at 2023 with our commissioners. So these are our experts, as Emily was saying. These are our experts, the community commissioners. And I wonder if you know of any groups or services or organisations that you're part of where you could recommend potential community commissioners to us. We would love to hear from you. And then what leaders are invited, as you saw from the video and as Emily explained, will be chosen by the community commissioners. So the civic and business commissioners that we're looking for, maybe you would consider becoming a civic or business commissioner on the commission. What would it mean? It would mean that you develop a deep understanding with others from the community. So it's about getting to know those people and really listening. It would offer a fresh hands-on perspective on your work. And you'd be part of a process of change in a different way of working. And it brings about lasting culture change and ultimately helps change attitudes towards poverty. So what could a Poverty Truth Commission do for you and your work? Does it sound like something you want to be part of? So at the end of phase 2, we have our public launch, to which obviously we'd love you all to attend and be part of the launch. It's the opportunity for community commissioners to share their stories with the wider community. And it's at this point that the civic and business leaders will be identified. We'll let you know the date once it's decided. That will come primarily from our commissioners, but we're hoping it will be around the end of June, middle of July. After the public launch, there'll be the full commission meetings, as you saw in the video. They're likely to be once a month and possibly on a Thursday lunchtime. So if it's something you're considering, that's the sort of timescale you'd be looking at. Plus, there'd also be opportunities to meet with the community commissioners over cups of tea, coffee if you prefer, you know, get to know these people as individuals. And this is where the relationships will really be formed between the two sets of commissioners. And then the task groups will come from there to work on the key issues that have been identified to unlock these creative solutions. We then move into the final phase in phase 4 at the end of the summer and have a closing event celebrating what's been achieved through the commission. We'll work with the commissioners to ensure that any recommendations are actually embedded in practice as well, so there'll be some embedding phase at the end. We don't know exactly what the outcomes are going to be. It's obviously going to depend on the commissioners that arrive and the stories that they have to tell and the things that they want to explore. But what we do know is that there will be change. There'll be change in the commissioners, both the community commissioners and the civic and business leaders. Nobody comes out of this process unchanged. And then those changes that happen will be fed back into their communities and their organisations. There will also be policy and structural changes as well, how things are done locally. And at the deepest level, there'll be culture change, a shift from the poverty that is the shame against it, into a shift that is the shame and responsibility of poverty being carried by us all. So I hope in this time that we've furthered your understanding of the Poverty Truth Commission, and you now know what we're looking for in community commissioners and also in our civic and business leaders. So once the community commission decide the direction of the commission, could we approach you or someone else in your organisation who holds the power within your organisation to join us? Do you want to be part of a process that would shine a fresh light on the work of your organisation? Please ask yourself and dare to dream, what if change is possible? So I have some contact details up there. If you want to get in contact with us, you can contact myself, Angela, or Emily at povertytruthbcp.org, and the website is the same. Thank you for listening today. I just want to check back with Emily if there's anything that you need to add to that.
No, I think that's a great summary. I just wanted to, I've been going around and starting, I'm working on the ground, particularly in the Poole area, because that's where I'm based, starting to recruit community commissioners. And it's been an amazing process so far. It's just deeply moving. And I just want to reflect back to a couple of things that I've heard as I've been going around. I was in one of the infant schools in Old Town last week, and just hearing people, I heard two comments that just moved me so deeply. There's one woman who said they were talking about the challenges of what was going on in their social housing, and she said, the fact is, to me, it feels like if you live in social housing, you're just trying to scam the system, and the deal is just shush, you got it lucky. And there was another woman I listened to who said, I just don't, and she said it with real compassion. She said, I just don't understand how those making decisions have got it so completely wrong. And that's a really painful thing to hear. It's a tough thing to feed back in, because you guys are doing we're all doing our best, aren't we? And so a Poverty Truth Commission is trying to bridge that gap, not in a way that says, not in an angry way that says all the community commission has got all the answers. They have an expertise and they have some of the answers. And actually, if those two groups can come together, that would be amazing. And then I just wanted to, there was one woman who, she listened to the process of what we were talking about, and you could see her gradually thaw out. She'd been quite kind of not sure about this, but gradually she thawed out. And then partway through, she said to me, but how do I know that they're really going to listen? And I suppose, we can reassure and say, for the reasons that I presented earlier, that we're setting up in a very different kind of way. But the other way that we can guarantee people are going to really listen is that we have the right people in the room. So just an encouragement back, if, you know, we will need, when we get to the point to be drawing in civic and business commissioners, you know, we need people who are in positions of leadership and, you know, have enough authority to be able to make a difference. And there is a time commitment, and it is, you know, you are very, very busy people, and your colleagues are very busy people, but we would love to invite you to consider whether this might be something you would like to be part of. So thank you very much for listening. We'd be very happy to take any comments or any questions. Be very interested to hear from those who have supported. I heard about the Poverty Truth Commission last year and have supported us in getting it to this point, and how you see it ties in with the work of the Health and Wellbeing Board, and any questions and comments. So thank you.
Thank you, Angela and Emily. That was a really good presentation, and I'm really glad that we got the video working eventually, because that was really great. So thank you very much. Jane, this is a lot of the work that you're already involved in, isn't it? With ABCD, I don't know if you wanted to comment.
Thank you. Yes, I have been working with Emily and latterly Angela all the way through the process so far, and really grateful that Sam has supported this initiative with the public health and the Outbreak money, I think it's really important that this happens, because not only does it talk to our strength-based aspirations, we want to listen to people, and that's what this is all about. It's about people listening to each other, because as Emily has just said, that perception of, you know, oh gosh, how did they get it so wrong? You know, we don't know that we're getting it so wrong. We feel and we hope that we're doing the right thing to make sure that our residents and our communities live the best life that they can, that can possibly happen. But if they feel we're getting it wrong, let's hear this, let's talk about it, and try and work out what we're doing wrong and what we can do to understand what's happening in those communities, because it's so important. We've just started the Vibrant Communities Partnership Board, which is a really operational board, and Emily has brought the Poverty Truth Commission to that board with, and so we're going to be watching that as it goes through as well. So yeah, totally in support, and really thanks to them to come and explain it today.
Thank you, Jane. Anybody else wishing to comment? Sam.
Thanks, Chair. I've just got a quick question. You might not be able to answer it now, but I was really struck by what you said when you said it's really important to try and slow people down. And I just wondered, from the experience of some of the past commissions, how effective they've been at actually getting the right leaders to devote the time and to devote the space, because the pressure to be busy is probably our greatest challenge.
Absolutely, and I think that's you've hit on one of the big challenges. And what very often happens is a Poverty Truth Commission will run once in a city or local authority, and then it will run again. And the first time it can be quite a struggle to persuade people to give time. Second time around, third time around, they've had people queuing up because they've seen the difference it makes. So yeah, I mean, Martin Johnson, who ran the first Poverty Truth Commission in Scotland, second time round they had they had people, ministers from Scottish Government involved, and he said they were tripping over themselves to be involved second time round. First time round, don't know what's this thing, you know. And his argument is actually people are desperately busy, and we really get that. But it's amazing how we can, without, and it might sound an easy thing to say, but we can find the space for something if we think it's valuable enough. So we would love to have conversations with people about why is it valuable, why might it make a difference? Because if we're going to ask you to give that time, there needs to be something coming back for you. And I think, I mean, there are various videos. There's a video from Morecambe Bay, or is it one of the other? Might be. I can't remember which commission it is, but I could share it. Listening to the experiences of civic and business commissioners when they what happened for them and the changes in them and the impact it had on their wider work, which just makes you go, oh, it's worth doing just for that. You know, people going, I wouldn't have missed out on this for the world. Yeah.
Thank you. Steve.
Thank you, Chair. I think I was interested about what Jane Kelly was just saying, because I was thinking myself about actually, is the Vibrant Communities Board a way for there to be a regular open means of communication from the findings of the Truth Commission to the Health and Wellbeing Board?
Thank you, Stephen. I think the answer is definitely yes. We're looking forward to it. Great. I'm not seeing anyone else. Sure. Can I just make a little point? And it's absolutely not meant to be anything critical, so forgive me if it sounds that way. But you were talking about professionals, and you were kind of referring to this room, and then you were talking about those who struggle. But I don't think there should be an assumption that if somebody's sitting behind a desk, that they're not struggling. And I think you'll find there are plenty of elected members and maybe officers who actually are struggling and are in poverty for various reasons. So I just like you just to kind of keep that in mind, that there's somebody who could be both types of commissioner.
Absolutely. Yeah, thank you for picking up on that. That's definitely true. And our experience of going out, I mean, it's been, we've been recruiting community commissioners through what we're calling community champions, so different people working in settings who can give us connections. And we've been finding that, you know, many of those community champions actually find themselves in that place. They're helping us recruit community commissioners, and then they're telling us some of their own stories. So yes, poverty has many, many faces, and we hear that, so thank you.
And thank you very much for your time. Right. We just have to have a quick look at the forward plan, and are there any omissions on the forward plan? Sam.
Thanks, Chair. Apologies, I'm rushing off that pesky busyness again. I just wondered, following the session on JSNA today, that really was the start of the process. So Karen and I have had a discussion about coming back to the board in June with a more formal sign-off. But before then, we'd really like to spend some development time, and we're thinking of a session in May to actually go through some of the findings in detail, but also some of those themes that are coming through quite clearly from what people are saying are the health and care themes that we ought to be looking at, and the sort of opportunities for integration. So it's just really to ask for the board's support in that session, really.